Hello, and welcome to the Maine Rural Healthcare Education Grand Rounds. On February 9th, 2024, we had the opportunity to host Dr. Annie Derthick of Central Maine Medical Center, and she presented her topic of competency-based evaluation and assessment. Unfortunately, the first few moments of Dr. Derthick's presentation were not caught in the recording, but we're happy to share her opening slides, and a few minutes in, her presentation will begin.
Set that emphasizes mastery and expertise rather than length of experience. So instead of having a fixed time approach, such as all residents will complete 2 weeks of a dermatology rotation, competency-based education considers how long will it take this particular resident to reach this particular desired outcome. So, in order to achieve all of this, programs and faculty really must pay more attention to the learning styles, goals, abilities of each individual learner and adapt teaching, learning experiences, and evaluation approaches accordingly. One of the foundations of competency based education is for the learner to develop critical thinking and self evaluation skills to consolidate the ability to become a lifelong learner. Dave, could you go ahead and click for me? So, why is all of this important? Why are we doing this? Well, despite spending more money per capita on healthcare than any similarly large or wealthy nation, patient outcomes are getting worse in the United States and have been steadily since the 1980s. The US has the lowest life expectancy at birth, the highest death rate for avoidable or treatable conditions, the highest maternal and infant mortality rate, and we have some of the highest suicide rates. The US has the highest rate of people with multiple chronic conditions and an obesity rate that is nearly twice the OECD average. Americans see physicians less than people in most countries and have among the lowest rate of practicing physicians in hospital beds per 1,000 population. COVID-19 recently reminded us that there are significant racial disparities. For example, Black women are 2 to 3 times more likely to die from pregnancy related complications than white women, with most of those deaths attributable to preventable causes. So, competency based medical education attempts to address these challenges by placing the family, patient, and community at the center of training. The ACGME, again, the accrediting body for graduate medical education, for example, requires that family medicine residents engage with the community health needs assessment, that our curriculum is derived from the community health needs assessment, so we're addressing the local needs. This requires flexibility in programming so that it's relevant to the local health needs. Go ahead and click for me, Dave. So Elaine Van Meel is the Education Research and Program Evaluation Specialist at the Department of Family Medicine at Queen's University. She's also the Education Scientist at the Royal College of Physicians and Surgeons of Canada. And she and her team were asked to develop a framework for evaluating the implementation of competency-based education in academic medicine programs. And they identified 5 core components of competency-based education. I've already mentioned kind of most of these along the way, but I'm going to focus on 2 of these specifically as I continue. Dave, do you mind clicking for me? So I'll focus on clearly articulating what the outcome competencies are and supporting and documenting the acquisition of those competencies or programmatic assessments. Dave, can you click for me? So clearly articulating what the outcome competencies are. In 1999, the ACGME and the American Board of Medical Specialties endorsed 6 domains of core competencies to provide the framework for the desired outcomes of competency-based medical education. if you've been through any residency, you are familiar with these, but it's not particular to medical education. Dave, can you click for me, please? Most every healthcare discipline has their own set of competencies. Dave, do you mind clicking for me? Um, Actually, I think you skipped one. So I had the ones for nursing up. Yeah, so these are the ones for the nursing. You'll see some areas of overlap here. There are a lot of similar themes depending on what discipline you're looking at, but there are very similar themes. Go ahead and click for me again. I don't know if you were here last time for Dr. Baraklis's talk, you might remember that at the end she demonstrated the iHELP-Maine learning platform and how it is arranged. So the team took, I believe, 20, she can correct me if I'm wrong, 20 different healthcare disciplines and looked at oh, good, I got it right, she's nodding her head. 20 different healthcare disciplines and looked at all the competencies for each and identified areas of overlap and really distilled those down to the most salient common themes, common competencies that were kind of trans-professional, trans-disciplinary, and we have organized resources around those. So these are the most common, most salient competencies, regardless of healthcare discipline, from medicine to nursing to emergency response. So go ahead and click for me, Dave. All right, so how do we document and support that learners, medical learners, are acquiring these competencies? Judy Powles is an icon in family medicine, and anyone who knows me knows that she's like my hero, and I can't give one talk without referencing her. So here's my token Judy Powles quote. All right, go ahead and click for me, Dave. So George Miller was an American physician and pioneer researcher in the field of medical education. He established the Department of Medical Education at the University of Illinois College of Medicine, and his work led to the AAMC, the Association of American Colleges, and multiple offshoot groups that focus on research and medical education. In 1990, Miller argued that traditional assessment relied too heavily on testing learner knowledge and not enough on assessing how they would behave in real life scenarios. So he proposed a new model that is known as Miller's Pyramid that you may have seen before, that divides the development of clinical competence into 4 hierarchical processes. So on the lowest level, you actually see is knowledge, which is tested by written exams, traditional multiple choice questions, etc. The next level stands for the application of knowledge, which is assessed by problem solving, case presentation. The third tier of the pyramid represents clinical skills competency, which is assessed by standardized patient experiences, OSCEs, SIM, those kinds of things. And then finally, on the very top of the pyramid, which represents clinical performance, is assessed by direct observation in clinical settings. And you can see as professional competency develops, as we are attempting to refine and support the development of professional competency, we rely less and less on summative evaluation and more on more frequent formative evaluation. So go ahead and click for me, Dave. Van Meel and her colleagues, when they developed the framework for competency-based education that had those 5 core components, they also developed a framework for competency-based assessment. They suggested that traditional forms of education and assessment were concerned primarily with identifying problem learners, but that competency-based education should be focused on promoting learning growth and development through more frequent formative assessment, as Miller had identified earlier on. And it does that through ensuring that there are multiple points and methods for data collection, by matching the quality of the competency being assessed to the method of data collection, by emphasizing workplace-based assessment or really real-life scenarios, by providing personalized, timely, meaningful feedback, by basing progression on entrustment, by making sure there is a robust system for decision making, and remembering that good assessment requires attention to issues of implicit and explicit bias, that can adversely affect the assessment process. So I want to look at a couple of examples about how to apply this assessment in a couple of different ways. So go ahead and, or sorry, this framework in a couple of different ways. Go ahead and click on me. Thank you. So I've chosen a couple of competencies here that seem to be transdisciplinary. So the examples that I might provide are more from a family medicine context, because that's my background, but they really do seem to be transdisciplinary. So patient care. Direct observation really is the primary method for assessment of patient care. Simulation can allow you to control the content and context. Learners demonstrate the shows how level of Miller's pyramid, which is clinical skills competency. This will also help you with the kind of entrustment piece of Van Mill's framework. But direct observation of real life encounters and other clinical activities is really essential. This is how you will assess that very top level of the pyramid, the learner doing the work of applying knowledge to actual patient care. And there are many standardized tools that can help you capture and document these live observations. So another piece of the framework is multiple points of data collection. So there's the mini CEX, which came out of internal medicine, but can be used regardless of the specialty. It is a formative assessment tool for outpatient and inpatient settings that evaluates several clinical skills, including medical interviewing, physical exam, decision-making, clinical reasoning. There's the OSATs that includes both formative and summative forms for assessment of procedural skill. There's the PCOF, which is a formative assessment of patient-centered communication. This one's great because there are forms available for basically every discipline: medical assistants, nurses, behavioral health providers, physicians, etc. You also will want to look for opportunities outside of direct patient care to assess skills as well. Some of our faculty, for example, have shift cards open when they are reviewing documentation, which will serve as a reminder to capture and provide feedback, but then also allow them to capture medical decision-making gaps that are not always observed in precepting. And you will want to look for opportunities to bring learners into quality and safety reviews, such as RCAs or peer review, is another opportunity to observe them and their critical thinking and medical reasoning. Okay, go ahead and click for me. This is an example of the shift card that we use in our clinic. We tried to make it as low barrier as possible. The faculty identify the competency that they want to evaluate the resident on, provide one piece of narrative feedback, which is please provide an example of something the resident did today that demonstrates the competency in the specific milestone above. And then please identify a specific milestone the resident may want to focus on for growth in the future. Obviously, personalized verbal feedback is best in the moment, but we really do need to capture that some way to document it so we can track it over time and it doesn't just get lost, dissipate in the atmosphere, because we do use these formative assessments to inform our summative assessments over time. So the idea really is that the faculty provides the resident the direct verbal feedback and then documents the conversation that was had on these very brief shift cards. Go ahead and click for me, Dave. So another quick example of applying Van Mill's framework to a specific subcompetency, medical knowledge. Performance on standardized assessments really sets universal benchmarks. However, these tests capture medical knowledge at a moment in time. And anyone who has ever taken a standardized test knows that the right answer might not be what you actually do in practice. So assessing medical knowledge and clinical reasoning in real time is essential. And this might be easier than it sounds because clinical reasoning is a complex process that is affected by a number of factors. And accurately assessing clinical reasoning requires expert questioning and the use of evidence-based theory. And there are a few structured tools that can help faculty systematically assess clinical reasoning, such as the chart simulated recall, which is a structured interview to complement chart review. So you actually sit down with your learner as you're reviewing their chart, and it probes for their medical decision making. So the two of you can review their chart and documentation together. This is based on the six competencies of ACGME. So for residents, medical residents, but it probes all six of those competencies. The assessment of clinical reasoning tool is a great tool. It's very quick and easy. It provides a structured approach to assessing hypothesis-driven data collection, problem representation, prioritized differential diagnosis, metacognition. And then clinical reasoning can also be assessed through observation and interactive methods like the SNAPS presentation model, for example. Go ahead and click for me, Dave. This is just a screenshot. I wanted to show this to you because if you're not aware of it, the Society to Improve Diagnosis in Medicine is a great resource. They're the ones that make the assessment of clinical reasoning tool available. But they also have on their website lots of little videos about how to probe medical learners for clinical reasoning. This is just two, but there's dozens on their site. So I just wanted to give you a quick visual of what's available. Go ahead and click for me. And I won't spend time on it now, but if these slides are made available, you can revisit this. This is from, I believe, the Physician Assistant Educational Association, which is a great resource. They have a ton of resources available for competency-based evaluation and assessment, but this will walk you through the SNAPS model of precepting. Go ahead and click for me. So how can you incorporate competency-based assessment? Where will you find the time to do all of this? Go ahead and click for me. So first, try and make the most of the time that you already have. So identify when and where you have opportunities to capture competency-based data. We have faculty meeting every week, and we start with what we call a milestone minute, where we bring a sub-competency up, we look at it, and reflect on opportunities we have to evaluate our residents on that sub-competency outside of precepting. Because the danger is that we will get 90% of our evaluations will be on medical knowledge and patient care that occur during precepting, and we won't have any data on any other of the competencies. So where else do we have opportunities to capture data on these sub-competencies? There's another residency that I heard of that sends a sub-competency out via email every month to residents and faculty, and then they post a question in the precepting area that will probe the preceptors, well, will probe the residents, but remind the preceptors to ask this question to probe the residents um, to ask a question about this particular sub-competency. So for example, one month was about patient-centered communication in the communication competency. And the question was, what are the patient's barriers to this plan? So for that month, the preceptors were probing residents to ask about the patient's barriers so that they could evaluate whether or not the residents were having these conversations with their patients. Look for time that you might be missing. So our entire clinic day was set up on the assumption that precepting took a specific amount of time. Our residents were saying that precepting took forever. Our faculty were saying that they didn't have enough time to do competency-based assessment. And I mentioned in a faculty meeting one day that there was some research that said the average precept should be about 8-9 minutes. And our faculty were like, no way, there's no way my precepts take that long. And I was like, oh, well, maybe I got that wrong. Maybe I misread that. So we collected data for a month. All of our faculty recorded how long each of their precepts took. And lo and behold, the average precept was like 9 minutes. And I was like, oh, maybe I did read that somewhere. So we actually used that data to restructure our clinic so we could factor in enough time to, instead of based on an assumption of how much time it took to precept, we actually used data to structure our clinic day. So there was some additional time to do competency-based assessment. Creating a shared mental model, I cannot understate how important it is that faculty and residents both understand what you're up to here. If you're speaking the same language, then residents will even prompt you to provide evaluation and assessment, that they will be using the same language that you need to provide accurate assessment. This is not something we have mastered. This is really where I see our residency needs the most growth, and where I'll be focusing our time for the upcoming future. Restructure your evaluation so that they include the competency language, and use the existing tools, some of which I provided today. Go ahead and click for me, Dave. So Van Meel's framework reminded us that good assessment requires attention to issues of implicit and explicit bias, so that we can mitigate any potential blind spots that we have in the assessment process. So go ahead and click for me, Dave. If you've ever read the book Thinking Fast and Slow, you might be familiar with the System 1 and System 2 type thinking. System 1 thinking is fast, intuitive, it's emotional, kind of that gut thinking. We take information in really quickly. It's associative. We associate that information with things we already know, or past experiences, or our emotional responses, and we make split-second decisions. It's very susceptible to bias. System 2 type thinking is much slower, it's more deliberate. We're taking in information, we're weighing it with evidence and self reflecting. Um, one system is not inherently better or worse than the other, they both have their purposes. Go ahead and click for me, Dave. So, if system one thinking is inherently more prone to bias, then why do we use it? Well, it's fast and it's easy. Also, our emotions are intelligent. They have something to tell us. Think about how many times your gut has told you something and it led you in the right direction. And it keeps things moving. And if you're in a busy healthcare setting, you need to make split decisions all the time. You have to rely on systems one thinking. It's not inherently bad, but it is inherently more prone to bias. And so we need to be aware of that. We need to acknowledge that and create some systems and processes in place that allow us to mitigate that bias. So go ahead and click for me, Dave. So here are some common cognitive biases. We probably talk about some of these with our learners in regard to their medical decision making, but they can also affect the assessment process as well. So the same cognitive biases that can influence the care of our patients can also influence the assessment that we make of our residents. So I won't go over all of these right now, but just to touch a few of them, like anchoring, we talk about that all the time in patient care, but can also affect assessment of our learners, relying too heavily on like one trait or piece of information. In-group bias, this is something that we don't like to talk about or say out loud, but the literature is very clear on this. We like people who are like us. We have an affinity for people who look like us, talk like us, come from the same region as us, come from a similar cultural background. So it's important to be aware of that when we are evaluating our learners. Are we potentially evaluating learners more or less favorably based on an in-group or out-group bias? And then the bandwagon effect, kind of that group think mentality. I have been in faculty meetings before where someone will bring up a complaint or concern about a learner, and then all of a sudden everyone else has a similar concern when they didn't seem to a few minutes before. Is that a bandwagon effect, or are those legitimate concerns that really do need to be addressed? And so just being aware of that, if everyone suddenly has a concern about a learner, is that potentially a cognitive bias? Go ahead and click for me, Dave. So how to mitigate some of these biases? There's lots of ways to do that. The same strategies that we talk to our learners about can be helpful for us as evaluators. But one kind of process to incorporate is the SCARE model. So first, slow things down. System one thinking happens when we don't have time to think analytically. Look for biases that might affect your assessment. Think about what your educational differential is. Is this truly a medical knowledge concern, Or is it potentially anxiety? Is it potentially a communication style difference? Is it a cultural difference? Is it just a bad day? So what's your educational differential? Review objective data from multiple sources and do some self-reflection. What could you be bringing to this? Could your assessment be affected by your own emotion, fatigue, distraction, or previous experiences? Go ahead, Dave. So that's all I had. Are there any questions or reflections or comments? Callie?
Annie, thank you so much. That was a great evidence-based review. Really enjoyed it and learned some new things as well, which I always really appreciate it. One of the things I just wanted to emphasize with this was this objective group think around evaluations. And it has sort of, it's been a mission of mine over the last several years to really encourage our residency programs to get away from group evaluations. And it's been a tough sell to some of our programs who have long had sort of faculty group think intentionally to create resident evaluations. But I do think that your example of one attending who may have had a negative interaction with one resident for whatever reason, including a bad day, and how that can influence future interactions. And so I really appreciated you bringing that up.
Well, thank you. I'm glad it's not just just my residency.
Annie, this is Bud Higgins. I work at Blue Water Health, and we now fortunately have a merge member at Holton, which is wonderful. I just want to say that that last slide of taking those biases that I teach residents and medical students all the time, but those have all been focused on patient care. I've never thought about using them to promote good comprehensive education. So I found that to be wonderful. And I will apply that and make sure some of my colleagues do as well. So thanks for that.
Yeah, thank you. Thank you for the reflection on that. I went to a breakout session at an AAFP conference 2 years ago on this topic, and it was really inspiring. So I've been incorporating it into all of my talks since then because I had the same reaction like, oh my gosh, we do this all the time. Why aren't we talking about how we're affected by the same biases? So thank you. Jim, did you have your hand up?
Yeah, Annie, I did. I was actually going to reflect the opposite of what you and Callie just said. No, is that sometimes the bias is in the other direction to favor the resident, and I've been in that circumstance, particularly with an advisor who heaps a lot of praise when the other faculty were just saying, but we have some issues here, and it sways the wrong way, and that's to the detriment of everybody, right? That's to the detriment of the resident because they're not getting the education they need, but obviously the detriment to our communities that we serve. So it's just one of those things where you just have to be cognizant of it and recognize that those kind of things occur, both with the independent bias and then with groupthink bias as well.
Yeah,
but great talk.
Oh, thank you, Jim. I didn't go over it specifically, but there is the horns and the halos, right? That sometimes residents can have a halo bias as well, that they come in and they are doing a great job or show up really well in a specific rotation, and we might be a little blind to some areas where they need improvement too. Julian?
Thanks. This was great. A lot of food for thought. In the very beginning, you talked about community health needs assessment. We seem to have an abundance of community health needs assessments at MDI. I mean, there's a state one, there's a local, there's island-wide referral base to a particular hospital. Which one are you using in all of this?
So at our residency, we look at our local Androscoggin, so I'm at Central Maine. So we look at the Androscoggin Community Health Needs Assessment. So it's kind of the most local. and have our residents use that for a couple of different projects. We have a community engaged learning curriculum. I won't get into the specifics of that right now, but they kind of have a longitudinal curriculum that starts in their intern year and gets more and more specific and engaged with the community over time until in their third year, they're actually collaborating on projects with community partners, but focuses a lot on population health and doing some quality improvement projects in the clinic throughout their time, but really using the community health needs assessment to guide all of that work.
Thanks.
We also
That's helpful.
formed, a couple of years ago, we formed a steering committee from the community, and they review our curriculum. The idea is that they will review our curriculum to provide feedback that we are emphasizing the areas that are of most importance to the community. Obviously, we have the standardized curriculum that we have to teach, like all residents have to have specific experiences, but where there is flexibility and where we have the opportunity to choose what we emphasize, are we emphasizing the right things? And so we meet on a semi-regular basis with the steering committee to review some of those decisions.
Helpful. Thanks.
Mm-hmm. Dave, do you mind clicking through and showing folks how to get I know you just stopped sharing, sorry, but clicking through and showing how folks to get the CME? Are there any final thoughts or questions? I appreciate everyone's time and attention today. Thank you all for coming and for all the good work that you're all doing.
Yes, thank you, Annie, for that. And yes, folks, the CME credits are now on the screen. I do encourage folks to collect that, make sure they text the number accordingly. And unless there are any last questions for Annie, then I'd like to close this out with just a couple exciting announcements. For one, I want to remind everybody this session and all Grand Round sessions are being archived on the Merge Collaborative website. And again, apologies for missing the very beginning of your talk, Annie, but I'll make sure to video edit in your slides with a brief description of what was missed there. Furthermore, Annie did talk about the iHELP-Maine platform. This is also accessible through both the Merge Collaborative website and the Building Maine website, which is clinicalrotationsinmaine.com. Both of them have an access point to this free learning platform with a variety of resources. It is continuing to grow and expand with our educational partners across the state. So I hope you have a chance to take advantage of that resource. And lastly, I just want to briefly promote next month's presentation. On March 8th, we will have Dr. Jim Jarvis of Northern Light with his presentation, Billing for Things Learners Do, or How Learners Can Help Your Bottom Line. So I'm sure some very practical advice. He'll be talking about the difference in billing practices between different types of learners and different locations of care. He'll talk about what services rendered by a learner are allowable for billing and how learners can assist in raising efficiency in your practice and increase revenue. So I'm sure for especially our leadership folks would be very interested to hear some of that very practical advice. So thank you everybody for joining.
Wait, I have one more.
Yes, ma'am.
I just wanted to let folks know that next week you'll get an announcement about the Merge annual conference, which will be held in association with the UMaine Biomedical Conference at in Orono on Thursday, March the 28th. This was a rescheduling of our October conference, and we really hope to see many of you for a day of education and to meet in person.
Thank you, Callie. That's right. And she's right. Next week is my plan for it. That'll be our 6 weeks in advance of the conference. So we're going to begin with a couple emails. If you were registered previously in the fall, you continue to be registered in the spring. And I believe some of you should have received an email directly from the symposium just checking in with you about your continued engagement there. I'll actually be copying in that information with my reminders. If you did not already register, don't worry. You've got 4 more weeks where you are able to register for the conference. So we would just love to have you. If there's any other questions, please don't hesitate to reach out by email. We're happy to help with whatever you need. And we look forward to seeing you in our upcoming events. Thanks, everybody.